welcome you all to this 29th international webinar. And this is also almost the first time that our original speaker fell sick, and we had to request our in-house stalwart, Dr. Narayan Pendse, to fill in the shoes. And we are extremely grateful that he acceded to this request at a very short time. And we have today Dr. A Lingaiah, who is the director heading the very prestigious Yashoda hospitals in Hyderabad. Dr. Lingaiah is a very well-known face to the CAHO family. He has been one of the pillars for us when we organized the CAHO conference recently. Dr. Lingaiah, the graduate from the Osmania University, and a very, very, I would say, respected medical figure in the entire state of Telangana. So over to you, Dr. Lingaiah, to introduce both the topic and the speaker for the day, Dr. Narayan Pendse.
Greetings to all. It is evening in India, so good evening to all of you. I welcome all the delegates who are participating in this program, and particularly our speaker. Within short time, Dr. Narayan Pendse accepted to talk in this topic. Today's our topic is key performance indicators, KPIs, monitor, measuring, and benchmarking. A very important topic. All of you know, even it is country or state or any organization, any industry, if it is more important in healthcare, particularly if you take in a hospital, each section of the hospital can have KPIs. For example, if you take lab, even lab also some sections are there. Histopathology, biochemistry, microbiology, even histopathology also, oncology, pulmonology, gastroenterology, separate departments are. Even in histopathology, breast cancer, ovary cancer, like that, we can go to any extent. So each individual also, it is for individual performance, so it is very important to measure the performance and which direction it is going, what is happening, what decisions we have to take. All these things are very important for this thing. So I profusely thank CAHO and ISQua for conducting this program, which is very important program for the hospitals, particularly healthcare sector. Because if you select a good KPI, which will be simple, appropriate, and if we collect data properly and analyze it, it will give decision for proper decision for decisions to us, which way we have to go, what we have to do. So very important topic chosen today, and today's our speaker, Dr. Narayan Pendse, is the appropriate person, is very experienced person in this aspect. He is now presently is MD Radiology and Master Public Health from University of London, and he is presently working in Fortis Healthcare Limited as a Vice President, Medical Strategy and Operations, Functional Lead, Clinical HIS and EMR Systems. He is NAB Check Principal Assessor, also lead faculty. He is CAHO Senior Faculty also. His key responsibilities are medical strategy and operations, including strategic planning, medical program management, health technology assessment, and clinical talent management. In healthcare IT section, design and implementation of clinical modules and EMR. In healthcare facility design, he is greenfield, brownfield, and expansion projects. He is a clinical governance, including clinical outcomes, quality, and patient safety accreditations. Other areas of expertise is public health, technical guidance, health system strengthening, and clinical radiology. Is a best radiologist, including teleradiology. With previous experience, he is HOD, radiology and imaging, Paras Healthcare, Gurgaon, and senior consultant in Indraprastha Apollo Hospital, Delhi. He is a consultant in Santoba Durlabhi Hospital, Jaipur. He is also international experience director, honorary director in operations, King's Hospital, Colombo, Sri Lanka. His technical assistance for health system strengthening, Republic of Burundi. His professional consultancy for renovation, restructuring, and relaunch of Oasis Hospital, Colombo, Sri Lanka. Medical strategy development, Fortis International Healthcare Arm, Mauritius, and is a consultant in Stop TB World Health Organization, Geneva, and he's visiting doctor for University of Hospital, Geneva. So with vast experience and with good wide exposure, he's going to talk about today about this topic, KPIs and monitoring, measuring, monitoring, and benchmarking. Sir, over to you, sir. Dr. Narayan, Pendse.
Good afternoon, everyone, and thank you so much, Dr. Lingaiah, sir, and thank you, Dr. Vijay Agarwal and CAHO. It's always a pleasure to connect with people and talk about quality, patient safety, and KPIs, and also share our experiences. It's always a learning for everybody, including the faculty. So I look forward to an engaging and participative session. So today's session, we are going to talk about KPIs for clinical quality improvement. As we all know that modern healthcare, not only modern, but since many years, we are moving into healthcare, which is essentially patient-centric. And what do we mean by patient-centric is that the entire care delivery planning, right from the planning stage to the operationalization, to the actual delivery of care, is targeted keeping the patient's interests in mind. And how do we determine what are the patient's interests? And when we talk about that, the outcome of care, both the process of care as well as the outcome of care, become of critical importance, because essentially that is what patients are looking for. They are looking for good quality health care. And what do we mean by good quality healthcare, or how do we assess whether the care being provided is good, of optimum quality and efficient or not? And that's where the concept of value-based care has now been established in healthcare. And what do we mean by value-based care? Value-based care essentially means that care which is of good quality, where the numerator is quality, divided by, and the denominator, that is cost. Because we all understand that cost of care is something that we all need to be conscious about, and it is not necessary that good quality care needs to be costly. On the contrary, efficient care has been found to be the best fit for any kind of health system, whether it's an advanced tertiary care health system, or whether it is a primary preventive healthcare system, etc. So two basic concepts of modern healthcare: one is patient-centric care, and second is value-based care, where value is derived by quality divided by cost. So for any particular procedure, let's say, what is the quality, and we'll talk about how to measure that quality. And second is, what is the cost of providing that particular care procedure. So that's essentially what value-based care means. And value-based care was a concept which was propounded by Professor Michael Porter of Harvard Business School, and has been found to be very useful, and it's becoming more and more entrenched in healthcare as we are evolving further. Good old adage, as we know, very, very true for quality, any quality, but particularly healthcare quality, is that if you cannot measure it, you cannot improve it, because fundamentally you do not know where you are. If you do not know where you are, which is the direction that you want to take, and how do you get to know that you are getting better or worse or the same? So measuring whatever we are doing is essential to the field of quality. But the key point then becomes that what is it that we measure, and how do we identify that what we are measuring is actually the one that is important for care delivery, as well as from the patient's point of view. So thankfully for that, some of the earlier stalwarts did a fantastic job. The one gentleman in question, I'm sure all of you have heard of the Donabedian model, and Evidis Donabedian was the one who propounded that model, which essentially talked about the importance of measuring all three aspects, that is structure, which essentially is the environment in which the care is provided, process, what care is delivered and how, And lastly, the outcome, that is the actual impact on the patients and or the population, depending on what type of care delivery model we are evaluating. What is essential is the relationship between process and outcome, because they both complement and supplement each other. Process compliance, better process compliance leads to better outcomes, and monitoring of outcomes informs whether the process of care, number A, is correct or not, and number B is whether it is being complied or not, and from time to time to identify the opportunities for improvement, leading to process improvement, so that the outcomes of care are even better. So a very important concept of measuring, because this is fundamental, whether we talk about service quality, whether we talk about clinical quality, the relationship between structure, process, and outcome, particularly process and outcome in most of the bigger, modern hospitals, the focus must be both on process as well as outcome, because like we just saw, they both supplement and complement each other. So what are some of the ways and methods of measuring quality of care? So some examples typically which are used for measuring quality, and I'm not talking here essentially about clinical quality, but in general, the quality indicators that any clinical dashboard or any service quality dashboard would include would be based on some of these things. For example, let's say efficiency. One of the key measures for efficiency of care could be, let's say, utilization rate. So you have the ICU utilization rate, or you have the operation theater, the OT utilization rate. It could also be, for various kinds of equipment that are, put up in the hospital. It could be, let's say, an MRI utilization rate, or a CT utilization rate, etc., which essentially talk about the efficiency of care and the cost part of quality. They do not directly measure quality, but like we have now come to know that efficiency and quality go hand in hand. So it is important that the resources that have been committed to care are also being utilized well by the hospital or by the healthcare system. The second common KPI which is used for measuring quality of care is turnaround times. We all in our hospitals, thanks to accreditations, etc., are now well versed with turnaround times. These turnaround times or waiting times could be for, let's say, for the patient to see a doctor in the outpatient department. It could be a turnaround time in case a referral is made to another doctor. Let's say a patient is in an emergency and there is a referral which is made to a surgeon or a gynecologist to come and see the patient. Then what is the defined turnaround time? And what is the compliance, that out of 100 cases, in how many was this followed? Because this is an important factor for clinical care as well as service quality. It could be time taken for indenting a medicine, for example. It could be time taken for discharge. It could be time taken for the surgery or a procedure to be carried out. So it includes both clinical as well as service quality measures. In service quality, we also rely a lot on gathering patient feedback. Nowadays, there are various channels, including whether it is by means of interview, whether it is by means of WhatsApp or SMS. There are various patient portals which can be used. NPS scores, etc., can be used. And this feedback could also cover clinical services. For example, was the patient satisfied with the way the examination was done, or the procedure was carried out? Were they explained well about the outcomes of the procedure? What would be carried out during the procedure, etc.? All that gets covered under patient feedback. Another important part is related to measuring the patient safety. So there are innumerable examples of KPIs like compliance to the surgical safety checklist. We all understand the importance of the checklist being used in the operation theaters. Medication safety is another example. Measurement of patient falls, etc. These are all covered under patient safety and are well established KPIs. Coming to clinical quality, things get a little more interesting. For my purposes, I typically divide them under two categories: generic measures and specific measures. Generic measures are not directly related to the procedure or to the health condition for which the patient is admitted or seeking care, but they are generic about the clinical quality of care. Let's say, for example, the rate of healthcare associated infections in a hospital. Now, this is something which may or may not be directly related to the procedure, but it is important because ultimately it reflects clinical quality. It could also lead to increased morbidity or sometimes even mortality. It could lead to increased stay in the hospital, increased cost of care, etc. So it's an important measure, indirect measure of clinical quality. And the other ones which are typically used for clinical quality measurement indirectly are returns. So let's say a return to the ICU after a patient has been stepped down to the ward. It could be a return to theater in case a re-procedure has to be carried out on the patient in whom the surgery was performed earlier. Return to ER is another very important parameter for measuring the quality of care of, let's say, the emergency department. So these are generic measures. I call them generic measures because they do not directly reflect the quality of care provided for that particular procedure or for that particular disease condition for which the patient is admitted. Those would come under specific measures, and these specific measures, for example, could be complications of a procedure. So let's say if a patient is undergoing a knee replacement surgery, what are the complications? It could be related to blood loss, it could be related to thromboembolism, it could be related to resurgery, it could be related to some residual deformity. Those could be some of the specific measures. For a GI surgery, these would be different. For a heart surgery, these would be different, and they would be more specific to the particular procedure or disease condition, and we'll talk about those in details. Two important areas when we talk about clinical KPIs, and there is fair bit of overlap between clinical KPIs, are clinical audits and quality improvement projects, because many times quality improvement projects could also be covering some areas of clinical service delivery. So there can be a certain overlap, but ultimately they all the intent is the same. The intent is to measure, the intent is to identify opportunity for improvement, and the intent is to make those things better and improve the overall quality of care. Now, like we talked about structure, process, and outcome, if one was to take the same approach to clinical KPIs, structure typically would cover, availability of certain things which are enablers for better care. For example, facilities, whether adequate room is available, adequate number of beds of different categories. It could be ICU bed, HDU beds, dialysis beds, emergency beds, etc., whether they are available or not. It could be related to staffing, another important area. We talked many times about nurse-patient ratios, doctor-patient ratios, technician-to-patient ratios, etc. All that would come under staffing, which would include both the quantitative aspect, that is number of people, as well as the qualitative aspect, which would then cover, credentialing, privileging of staff, whether the staff being provided are of proper qualifications and adequate experience or not. It would also cover equipment. For example, if you have a setup which takes care of acute stroke, then do you have adequate equipment to take care of such patients or not, and is that service available at 24/7 or not, etc. Qualifications we already talked about. Licensing and accreditation could be other measures related to structure. But fundamentally, in modern healthcare, especially in the setups like most of us are from, structure really doesn't come into play too often. So what we focus largely is on process and outcomes. Processes could involve aspects of technical care. Let's say screening of patients for a particular health condition. Let's say screening for thromboembolism, for example, for patients who are getting admitted for elective surgeries. Screening for control of diabetes by doing a HbA1c level, for example. It could also include preventive aspects, diagnostic aspects, treatment, and follow-up care. It would also typically involve interpersonal care, communication, knowledge and information transfer between various, multidisciplines which are involved in care to the patient, etc. But more and more, the important part has now shifted to outcome, which is that essentially means what is the actual outcome of care for which the patient has sought treatment at the hospital. It typically would involve criteria which cover acute recovery, let's say condition at the time of just after the procedure has been carried out. It could be at the time of discharge. It could be related to restoration of function, for example, knee replacement, hip replacements, etc. What is the degree of mobility? It could be related to survival. Cancer, for example, typically talks about 5-year survival rates, etc. It could also be related to efficiency of care. And some of the common things which get measured under outcomes of care would include morbidity and mortality statistics, surgical site infections, disease-free survival rates, quality of life, another important areas. And very importantly, in today's time with patient-centric care, they would cover patient satisfaction. And we'll see some of the examples during today's talk. So what are essentially, quality indicators? So I'm sure all of you know what quality indicators are, but just a very brief recap. These are measurable, objective indicators of quality. They offer a quick, simple insight into the level of quality and its pattern over a period of time. They need to be monitored continuously, especially for trend monitoring. Again, the idea is to identify the opportunities for improvement so that adequate and appropriate measures can be put into place to improve the level of care that we are providing. Very importantly, Dr. Lingaiah talked about this briefly in the preface. Quality indicators should be objective, so that anybody who is measuring it is measuring in the similar manner. They should be important and relevant to our scope of services, or to the problem or to the condition that we are evaluating. The potential for, it should have a clear potential for use. For example, when a problem is identified by measurement, it should be possible to respond to it and upgrade the quality, and that's the ultimate intent. They should be reliable, very clearly define what is going to be the numerator, what is going to be the denominator, operational definitions, data collection methodology, etc. And very importantly, the indicator should be adequately reflective of the problem which is being monitored, which is a term which is referred to as validity of the quality indicators. And we will see some in the examples that we go forward with. So measuring the quality of care, like we talked about, in the previous slides, that we can look at efficiency through utilization rate, we can look at service quality with turnaround times and patient feedback, etc. We can cover patient safety as well as clinical quality. So if one has to essentially look at a sample dashboard, here I'm talking about the generic measures that we saw for clinical quality. It could look something like this. This is a dashboard which I have taken from my organization, which is Fortis. This is the older version, but essentially here the idea is to show what is the concept of putting together a dashboard. So at that point in time, few years back, the parameters that are listed here on the left hand side of the table were the ones that you see here. We were measuring, let's say, cautery burns. We were measuring catheter-associated UTIs, CLAPSIs. We were also evaluating the return of spontaneous circulation in cases of CPR, death within 48 hours of surgery, death within 48 hours of a coronary angioplasty, so on and so forth. The idea is just that, a simple table or a dashboard on which the various hospitals can be evaluated as at a quick snapshot, along with the target which is defined, whatever the target could be. And the targets or benchmarks are typically taken from national or international sources, which, for example, for healthcare associated infections, typically would be a CDSC, NHSN, benchmarks that one take. One could also look at other studies like the IONIC study for CLAPSI, VAPS, etc. But something like this, typical, and I'm sure most of the hospitals here who are participating would have their own, sample dashboards which pick up these generic measures for clinical quality, surgical site infections, ventilator associated pneumonia. The definitions may have changed. Now you have the VAE, VAC, IVAC, etc. But essentially the concept is something like this, to put together a dashboard for one hospital or maybe for a chain of hospital, and see it on a monthly level to pick up the trend. Is there anything that is going wrong, so that something needs to be adjusted, somebody needs to be spoken to, some training needs to be conducted, etc. And it needs to be uh, evaluated further. Always, while depicting your dashboard for performance indicators, it's a good idea to do the trending. The trending could be on a weekly or a monthly basis. It could be on a yearly basis. For example, here what you see is a year-on-year comparison of VAP and surgical site infections, while what you see at the bottom is a trend graph which is on a monthly basis, along with the upper control limit and the lower control limit which have been put in, and the benchmark which you can see in the dotted line, the blue dotted line in the center, is the NHSN benchmark. So one can very easily on this graph see how the hospital or the healthcare organization is doing with respect to this particular parameter. Now coming to the core topic for today, which is how do we measure clinical quality by using specific measures, that is measures which are specific to the procedure or to the disease condition, and let's look at some of the examples for these. So clinical quality indicator as a concept is not something which is very new. It has been in use by health services since the 1980s. It finds a lot of mention under clinical governance, at least the NHS model which started. Like I mentioned, there is a fair bit of overlap between clinical audits, clinical outcomes, clinical quality indicators, and quality improvement projects. But it's not important to define and delineate all of them or put them into watertight buckets. That's not the idea. Even if there is some overlap, ultimately all of them are working towards the same purpose: to measure, to identify potential for improvement, and to put into effect the appropriate measures for doing so, in discussion with the clinical teams, paraclinical teams, etc., so that the desired result can be achieved. Increased awareness of quality and safety issues, and in last 20 odd years, with accreditation becoming big and becoming realized to be an important tool for quality, these have seen an expansion, and development of clinical indicators for specific disease and procedure types have also been put into place. It is also because of changing models of care. For example, insurance companies, earlier a lot of the payment used to be cash or directly from the patient. In today's time, and even in India now, the healthcare insurance, whether private or social health insurance, is becoming a big and important driver for measurement of clinical indicators. So preferential reimbursement rates, for example, already the state, the social health insurance schemes, they give preferential reimbursement if a hospital is accredited, let's say by NABH or JCI or similar. But going forward, already work is in progress to actually measure the clinical indicators or the clinical outcomes and link the reimbursement rates to those. Clinical indicators should measure the process, structure, and outcomes of patient care. And very importantly, they allow clinical care to be monitored over a period of time and to be benchmarked against the established standards of care. And we'll see some of these. They serve multiple purposes. They help benchmark care. They help in arriving at a benchmark. For example, a global benchmark, or let's say a benchmark which is taken from a certain set of population, may not directly be extrapolatable to any other population or any other healthcare system. So for that healthcare system, measuring of clinical indicators could throw up relevant or appropriate benchmark for those subsets of populations. They help make judgments about services. They help set priorities, system wide or service wise, organize care, document the quality of care, and very importantly support accountability and transparency. We all we looked at patient centric care. One of the patient centric care pillars is accountability and transparency, and that's essentially what measuring clinical KPIs does. Clinical indicators may point to system level issues. However, they are rarely specific enough to provide an insight into an individual doctor's clinical performance. So this is a very important point. That's why I put it in highlight in a block. What we are trying to do here is to measure by means of appropriate clinical indicators. We are not here to measure anybody's competence or individual skill. We are here to see the model of service care delivery for clinical care and how it can be made better. Of course, individual performance, credentialing, privileging, skill competencies are important. But here, when we talk about quality improvement, we are looking at a system level quality improvement, and that is essentially what clinical indicators do. For personal, evaluations, etc., there are other methods like peer review of cases or surgeries, proctorship, mentorship, etc. Some of these overlap with privileging, etc., and those will not be typically covered under clinical indicators. So that's an important disclaimer for everybody to understand. An ideal clinical quality indicator must be evidence-based, very important, because there should be data or statistics to support that quality indicator. It should be valid and reliable. It should be able to permit useful comparisons. It should be relevant to the important aspects of the quality of care. It should be relevant to the important aspects and dimensions of the quality of care, for example, effectiveness, safety, efficiency, etc. And it should be feasible, that is, it should be appropriate, measurable, and improvable. So with this entire theory, let's look at some of the simple examples which could be there. Let's say for patients undergoing coronary artery bypass graft surgeries. Now there could be a host of parameters which could be there, which could cover structure, process, and outcome. One of the parameters, very important and well established, evidence based, is that what graft is used for carrying out the bypass surgery. So essentially there are two types of grafts. There are arterial grafts and venous grafts. Arterial grafts are better. This is backed by enough data and statistics and science that arterial grafts in bypass surgeries are better. And the best graft, even within different types of arterial grafts, is supposed to be the one where you take the internal mammary artery, which is an artery in the chest wall of the patient. If that internal mammary artery or internal thoracic artery, as it is called, if that artery is used to perform the graft surgery, that is supposed to be the best. So it's a very clearly defined evidence-based clinical parameter for evaluating coronary artery bypass graft surgeries of the hospital or the healthcare system. The indicator could be percentage of patients in which the left internal mammary artery graft, or LIMA as it is called, is used for bypass surgery. Okay, so that could be an example. This is evidence to support, and today's time, thanks to Google and others, it's easy to pick up the evidence base. Society of Thoracic Surgeons, STS, for example, clearly states that LIMA use is a great parameter to evaluate clinical quality with respect to CABG surgeries. Like I said, it is important to define very clearly each clinical quality indicator or parameter. So in this case, the numerator would be number of cases where LIMA graft was used. The denominator obviously would be number of patients who underwent CABG surgery during that period. It could be a month, it could be a fortnight, it could be a year, it could be more. So the denominator has to be very clearly defined. So the formula typically is that of a percentage. So numerator divided by denominator multiplied by 100 would give you the percentage compliance to LIMA use, and then the appropriate benchmark needs to be selected. For example, the internationally accepted benchmark by STS and by the American registries is 85%. So that would very clearly define your one of the clinical quality indicators for CABG surgery. Easier said than done. There could be other parameters also. In some cases, the LIMA may not be possible to use LIMA. We could also look at other parameters like perioperative complications, like how much time did the patient require to be in the ICU after the surgery. Was it less than 48 hours, less than 24 hours, more than 48 hours, more than 72 hours? Because that would reflect on the overall quality of the clinical quality in the procedure that has been carried out. It could also be related to let's say how much blood products were used during the surgery, could be another indicator. After the surgery or within the surgery, did the patient have any fresh heart attack or an MI? Could be another clinical quality indicator for CABG surgery. Did the patient suffer any post-operative neurological stroke? What was the number of patients who died after bypass surgery, and so on. You know, if you look at structural indicators, it could be whether a cardiac anesthetist or perfusionist were available, whether the required, you know, equipment like a heart lung machine or a intra-aortic balloon pump were they available. These all could be structural indicator. So all process, outcome, as well as structure can be covered with respect to one single surgery, which in this example that I am giving you is that of a CABG. These could also then be put up very clearly into a tabular form. Um, there could be risk scores which can be calculated. For example, Euroscore 2 that is listed here is one of the best tools to measure the risk category or the chances of, you know, mortality in the patients who are undergoing CABG surgeries. It's important to do this risk categorization. I'll talk about this in one of the subsequent slides. ICU length of stay, we already talked about. Use of Lima graft, we talked about. Surgical prophylaxis, another important area because of surgical site infections, etc. So if you see on the right hand column, you will see that these are divided into process as well as outcome measures. And most of the times when we talk about clinical KPIs or clinical outcomes, we would select the outcome parameters to be the most important, because those are the ones which actually matter the most to the patient. For each of the parameters, it is very important to define the operational characteristics very clearly. So for example, if one was to look at, let's say, ICU readmission, so the requirement of a patient to be transferred to the ICU after initial discharge to the ward, not including step down units, including date of readmission and date of discharge. So it's a very clearly defined objective criteria for ICU readmission. Similarly, after surgery, did the patient have a stroke? Now, how do you define a stroke? Because stroke could mean different things to different people. So you need to define stroke very clearly. So in this particular case, for example, the definition is a central neurologic deficit persisting post-operatively for more than 72 hours with evidence on an imaging study. So a CT scan or MRI has to be done which depicts a fresh stroke and or a neurologist confirmation. So again, it is very clearly defined and objective criteria have been provided. This is the importance of attaching the operational definition when you are defining your clinical KPIs. When it comes to clinical quality, obviously the biggest stakeholders are doctors, and it is very important to have very clear evidence-based and data and statistics to take to them so that they can select the parameter and do the benchmarking accordingly, because ultimate idea of clinical KPIs is to stimulate improvement. Now, who is going to bring in that improvement? Obviously, it's the clinical teams which are going to bring in that improvement. Without their involvement, without their engagement, it will not be possible to improve quality of care. So it's very important to have these quality indicators based on evidence from very well established sources. We already talked about, for CABG, let's say structure, process, and outcome, what could be the examples. And we'll share these slides after the presentation for all of you to peruse. Like we saw the earlier, quality scorecard. Similarly, you could have a scorecard for a particular procedure. Let's say for CABG, you could look at the parameters that you have selected. Let's say here the parameters that have been taken are listed here. And for with different hospitals, there can be a comparative table which can be provided along with the benchmark. So let's say, for example, in this particular hospital for CABG surgery, the benchmark for Lima grafting is 74.2%, which they have taken from the Cleveland Clinic's report of 2014. It's an outdated one, but the idea here is to just give you the approach for setting up a clinical KPI dashboard. Against this benchmark, what is the actual Lima use in different hospitals could be seen. So for example, here, if you see hospital A, the Lima use is 64%, hospital B, it is 80%, and hospital C, it is 100%. So obviously in this particular parameter, we see that hospital C seems to be the best performer. But again, word of caution, because data can be quite tricky. It also depends on what is the actual number of cases. It may be that hospital C operates on very few patients. Risk categorization also becomes very important, because it could be that hospital C operates on very select patients, elective surgeries, safer surgeries in that sense, where Lima is available for harvesting, while hospital A may appear on this statistic to be the worst, but actually may be taking up most risky cases for surgery, or that the number of cases would be very many, etc. So there are multiple factors which need to be looked into while you are analyzing the scores. Similarly, for PTCA, coronary angioplasty, you could define your parameters. Did the patients require any emergency surgery during or after the course of the the angioplasty? Number of stroke episodes after angioplasty? How many patients who earlier had a normal kidney function required a dialysis after angioplasty? So on and so forth. You could also select, clinical KPIs for the particular procedure, which in this case is angioplasty. Again, like we saw earlier, there could be a table that you can put up along with some of the key service quality parts also. For example, for acute stroke patients, what was the door to balloon time, or what was the time to the first ECG, or time to do a TROP-T test, which is a cardiac enzyme which gets raised in acute MI patients. And some of these could help you identify the topic for a clinical audit, so that you can look at the gap and what is the specific measure which needs to be put into place to improve the quality of care with respect to coronary angioplasty. Uh, you could also set up scorecards, KPI scorecards for different departments. This is an example for a maternal and neonatal unit. Let's say, for example, post-operative deep vein thrombosis, maternal death rate, excessive blood loss, third and fourth degree obstetric trauma. But whatever you select, be very sure to define the numerator, denominator very clearly. What is the value of the formula? Always identify a benchmark and measure against the benchmark, do the trending and see whether the quality of care. Uh, can I request participants to be on the mute their microphones, please? Thank you. Similarly, C-section rate, for example, birth trauma, unexplained fever during labor or delivery. These are examples of putting together a clinical KPI dashboard for a particular department, which in this case is maternal and neonatology. Similarly, there could also be for other minor specialties. I hate to use that word minor, but sticking to conventional sense, please don't take it otherwise if there are any ophthalmologists here. It could be, let's say, for ophthalmologists, that what is the percentage of infectious endophthalmitis, which is a dreaded complication of cataract surgery. What is the benchmark that this particular hospital has taken? It is less than 0.2%. This is taken from the National Eye Database, Malaysia. The numerator and denominator are very clearly defined. That the numerator is number of patients who developed infectious endophthalmitis following cataract surgery. Denominator is the total number of patients who underwent cataract surgery, and you could put together on a monthly or bi-monthly basis a scorecard for a cataract surgery, for example. And these are again parameters, which indicators which can be used for putting together the specific KPIs for, let's say, cataract surgery or vitrectomy, etc. Similarly, if one looks at, let's say, gastroenterology, there could be quality indicators for ERCP. Pretty much any procedure. I'm just giving you examples to illustrate or drive home the point that it's not only for, let's say, heart surgery or major surgeries. ERCP is an outdoor or a daycare kind of a procedure, but you can pick up quality indicators for GI endoscopic procedure also. And there is a very good resource which is available here, which is this joint and advisory group. We use their reference to define our own criteria for ERCP. For example, was there any drop in the hemoglobin level, or did the patient require transfusion? Did the patient develop pancreatitis post ERCP? How do you define pancreatitis? So it would be that the enzyme levels were more than 3 times the normal. Did the patient have any complication, morbidity, mortality, infection, gallbladder infection, etc.? So again, these could be put together to have a clinical quality dashboard for ERCP procedure. Now, what are some of the resources for indicator selection? Like I said, for CABG, the Society for Thoracic Surgeons is one of the very good websites or forums where this can be picked up. It's a free resource available to everybody for reading. You could look at sources like those. You could also look at publications which are available online. For example, clinical outcomes. This is from St. Luke's Medical Center. Now, while it is important to look at clinical quality, if one looks at from a comprehensive quality care point of view, one could involve non-clinical parts for a department dashboard also, like operational. We talked about some of the service quality parts like turnaround times, etc. Those could be added for the operational ones. Let's say if I were to make a dashboard for my cath lab, I would typically involve some of these things, like what was the operational part, like what is the turnaround time between cases, holding times, etc. I would also look at financial part, like what is the number of overall volumes, how many numbers I've done on my cath lab, what is my utilization. I could also break up into what is the number of diagnostic angiograms, what is the number of angioplasties, what are the number of electrophysiology procedures, etc. I could also look at what is the payer mix, for example, what type of class of patients I am tending to, whether they are cash patients, whether they are insurance patients, etc. What is the average cost per case? What is the average length of stay in the cath lab? And of course, I would have my clinical quality indicators like mortality, morbidity, complications, etc., which we just talked about a few slides back. All these could be put together onto a dashboard. You can use Excel to create some of this. In every hospital, you will find a good person, who is familiar with a lot of Excel. They can be done, or there are softwares on which these can be created quite easily by yourself or by using a third party. And these could be available for doing a simple trending, whether the trend is upswing, downswing, etc. Can be seen in a visually attractive kind of a manner. So like I said, sometimes there is overlap with what people think as clinical audit. Clinical audit also essentially monitors clinical quality, selecting a particular outcome indicator and how to improve that indicator would be a good topic for a clinical audit. Let's say, for example, if I find in my hospital A, which had a 64% Lima use, I know that there is something wrong because the benchmark ideally should be around 80-85%. So how do I increase from 64% Lima use to the benchmark is something which could be a topic for a clinical audit for that hospital. So ultimately, all of them are working towards improving the quality of care, and it can be looked from that aspect. Whenever you are planning to set up clinical quality indicators, pick up the ones which are relevant to your hospital. For example, for this particular hospital which I have taken as an example, in phase 1 they decided that okay, we are only going to look at 3 procedures, which is at coronary angioplasty, bypass surgeries, and knee replacements, because these are the 3 which probably are important to them. For some other, it may be the eye surgery ones that I was talking about. Decide on what are the outcomes or indicators which will be recorded and reviewed. Speak to the concerned stakeholders, set the targets, develop the improvement plans, and then review the progress from time to time to be able to identify the opportunity for improvement. I'm not going to go through the each of the indicators. I mean, these are pretty standard. Like I said, we'll be sharing the deck with you so you can make use of it later also. Very importantly, it is always good to define the governance structure as to who is going to be responsible for the clinical quality indicator with respect to that particular procedure, or that particular specialty, or that particular disease condition. So it could be, typically, let's say the head of department, if your hospital has a department structure, it could be something different in different hospitals. But essentially, the clinical leadership of the hospital must be engaged whenever we talk about anything to do with clinical quality. This is not something which the quality department or the quality nurse or the quality manager can drive on their own. Of course, they are needed for any quality improvement, measures and overall for the initiative. But primarily, the the responsibility lies with the clinical leadership, and of course with good support from the management teams, from admin teams, nursing teams, etc. But the governance structure needs to be defined very, very clearly. Who will be responsible, where this data will be presented, what will happen once this data is shared, etc., etc. This is just an example of a data collection portal. This is the one that we had developed in-house many years back. Now there are more fancy versions like these ones that I'm showing you here, where you can select a particular parameter and see, what patient ID was this particular, outcome, adverse, etc. And you can quickly do some kind of a analysis. These help you also generate graphs and stuff like that, so that they are easily understandable or presentable to a wider audience. Uh, Always remember, statistics are open to different interpretation. Like I was giving you the example of hospital A, B, and C. Always look at the number that is there in the sample. For example, while somebody may say, hey, my success rate is 100%, it may be the patient operated is only one. So obviously, if one surgery, one success doesn't mean it's, I mean, literally it means 100%, but from a quality improvement product, it's too insufficient a sample to be able to come to any kind of a conclusion. It's also important to understand the importance of risk when we talk about clinical procedures. Let's say in this case, Dr. A has a 3% complication rate versus Dr. B, who has 13.2 complication rate. Does that mean Dr. B is unsafe or riskier or not a good surgeon, while Dr. A is a very good surgeon? Not necessarily. We don't know enough. We don't have enough data to come to that conclusion. It may be that the number of patients who Dr. A operates are very few. It may be that the patients who Dr. A selects, he selects only patients who are of very low risk. So naturally, the success rate is much higher and the complication rate is much lower. While Dr. B may be working in a healthcare system where he doesn't have a choice of refusing patients simply because they are high risk. Somebody has to do surgeries on high risk patients also, if that is the only recourse. So obviously the complication rate in case of Dr. B is going to be higher. So whenever we are interpreting anything to do with clinical quality, clinical measures, clinical outcomes, etc., we need to be understanding that risk adjustment or risk standardization, risk stratification is a very, very important area in this. So beware before jumping to any conclusions as far as clinical quality indicator interpretation is concerned. Obviously, a lot of challenges, standardization, agreeing upon what procedure, what parameter, how to standardize. It's a challenge. Collection of data, because many times this data is lying in case files, etc. Somebody has to go, somebody has to enter. Many times doctors or they may be understaffed, they may be overworked, they may not have enough motivation to do that. It becomes a challenge. Many times it is the accuracy is questionable, because even if you show this data somewhere, people might say, hey, you are only going to show good data, but we don't necessarily trust it. How do we know that this is accurate? Is there any third party audit which is going on, etc.? But gradually things are changing, people are understanding, and I'm sure that more and more checks and balances in agreement with all these stakeholders will come into picture. Many times patients don't turn up for follow-up, particularly in private hospitals. People come from far off to get their surgeries done. The follow-up is done at their own local GP level, etc. So we don't sometimes get data of follow-up, etc., long-term follow-up from patients. Organization culture, sometimes that hey, steer clear from doctors, don't touch them, that may be a problem. Clinician ownership, because like I said, ultimately without their engagement, without their ownership, very little can be achieved. And if the clinicians are not convinced that what's in it for me, it's going to be difficult. But things are again changing. Doctors are also very much in today's time aware and cognizant of these fact of quality improvement, quality measurement, etc. And it's a step in the right direction. So some common fallacies or some common myths. I mean, many times people ask, so is a clinical indicator, does it only mean the success rate of a procedure? Not really. The indicator is there to measure by virtue of other indicators together, which are put together for a procedure, to overall look at the care delivery model for that procedure. It's not, success rate of a procedure is just one small component of the clinical quality indicator dashboard for that procedure. Does it mean measuring the complication rate of a procedure? No, not really. Complication rate again is a small part of the overall quality measurement as far as the quality indicator for clinical quality are concerned. Is the purpose to compare hospitals and doctors with each other? No, not at all. That's a slippery slope. The idea is to look for opportunities for improvement within the department, within the hospital, within the network of hospitals, or at a healthcare system level. That is the intent. The intent is not to assess or show somebody down that, you know, your success rate is much lower than my success rate. That's not the idea at all. I already talked about how it is different from clinical audit, and how you know, clinical quality indicators can stimulate clinical audit. So very important, probably the penultimate slide, that in today's time, it's not only important to measure outcomes that are recorded by us, which is the healthcare providers or the clinical teams. It is also important to measure outcomes from the patient's point of view, that, you know, has the patient really improved with respect to the disease condition for which he or she had sought care from the hospital. So these are called PROMs, or patient reported outcome measures. All accreditations, etc., nowadays have included PROMs in the accreditation requirements, and I'm sure most of you are now familiar or getting familiar with PROMs. So finally, the 10 commandments for clinical quality improvement using KPIs like the ones that we were talking about, or clinical outcomes, or clinical audits. Prepare well, get adequate information, do your groundwork. Always good to engage with all the stakeholders, including doctors, nurses, management, admin teams, etc. Reassure people for the purpose, like we talked about multiple times. The purpose is quality improvement. Purpose is not to judge anybody's skill or competence. Start small, gradually move to the bigger you know, scale of implementation. Always check, monitor, and analyze. Ensure that there is good teamwork, because otherwise one will not be able to reach anywhere in such a complex kind of a quality journey that we are undertaking. Indulge in advocacy. Internal customers, doctors, for example, are very important in this particular stream. So, you know, engage with them very well, do your advocacy, give them opportunity to present their concerns, talk about, you know, what are some of the ways by which we can improve, be aware of the gaps which can be there in data analysis, etc. Standardize, make it as objective as possible. Patience and perseverance help. Don't be over ambitious in achieving great results in a very short time. Clinical care doesn't work like that. It takes time to you know, reach there. And very, very importantly, build a culture of quality and safety. Some of the references I have used for this presentation, but like I said, there is no dearth of you know, clinical resources now available online. Please feel free to make use of them. We can take a few questions. Thank you.
Thank you, Dr. Narayan. Very well done. You have spoken very well about the KPIs and measuring, how to measure it. You told patient-centric, patient safety is most important, and most of your talk is about clinical quality indicators. Yes, that is correct. And value-based care is most important, and cost. You told about cost also. Yes, nowadays people are coming paying the for their treatment, so they think they always think about the value of the service what we provide for their payment. So that is very, very important point you have told. And one more point what you have told is clinical leaders in the hospital are most important, because quality people only cannot do this. Everybody, including clinical leaders, the management should help the quality people to improve the quality, and the team coordinator should also be there. You told about dashboard also. Yes, dashboard and Excel sheets, and then tables, all those things. Yes, it will quickly, they will tell us what conclusion we can come to conclusion very quickly. So very good talk. We have explained everything in detail. All of us, we know that KPIs are very crucial. If we select good, appropriate KPI, it will be very useful to monitor, analyze, optimize all healthcare related process. But tracking, we need the right KPI, which should be measurable, achievable, relevant, and time bound, which reflects about the performance of an organization and shows directions and provides insight that enables to know progress, success, or failure, and change in the strategy or policy accordingly. So with this, I will open this thing for questioning. If anybody has any question, please you can talk question and ask questions.
Thank you. Thank you so much, Lingaiah sir and Dr. Narayan. Question that's asked, I have been seeing it here about SMR and how to calculate the standardized mortality rate. Do you want to take that, Dr. Narayan?
So SMR is, I mean, it's a well-established tool in today's time. It's also now, become an accreditation requirement, and there are tools which are available to, madam, guide on SMR, and we can share the tools with the participants if that's okay, because that would be a topic in itself. We did touch upon risk stratification, etc. So SMR is a step in that direction, and we can definitely share the tools, because otherwise it will take a fair bit of time if we get into the SMR discussion at this point in time.
Absolutely. So I think we should have a very focused session on that. The second question is, how do you validate the data of KPI? What percentage and how do you document a data validation? I think this is very specific to the NABH requirement of validation.
Yeah. So in my view, essentially, the data validation should be done by, you can't really go to a third party outside the hospital to do a data validation, especially for clinical data, because there are, sensitivities around that. So it is important that, like I said, the ownership and engagement with the clinical teams is most important. Usually the way it works is that, once the clinicians are convinced, they will find somebody from their team or from their department to kind of help with putting together this data. The data sources, where will you find this particular type of data, let's say in the case sheet, something maybe in the discharge summary, something maybe in the lab test report, etc. So anyway, these can be validated easily by somebody doing a retrospective audit, and this could be a sample based audit done by somebody who is part of the overall quality improvement team to be able to validate the data. And in case there is any gap, be a little charitable and generous and point out that, there are few gaps which we need to fix so that these can be addressed. Again, the idea is not to sit in judgment on anybody or to look at people with a negative sense, but we are all prone to errors and we are all fundamentally here to improve. As long as that is the spirit, the validation can be carried out in the right manner, but it should be done by somebody who understands the process, who understands the the clinical procedures, the data sources, etc. That is most important, particularly for clinical KPIs. I mean, absolutely.
Lingaiah sir, your thoughts?
Validation is very, very important, yes, because it's a very good question, because people will put, as Dr. Narayan told about tricky data. Tricky data is there, so people may manipulate it, or all those things will be there. So validation is a very important point. In organization, there should be a neutral body which should validate the data, whatever is there, to, as Dr. Narayan told, retrogradely, they have to see whether the data presented or not. They have to verify and validate the data. And if you want to go inter-hospital and all those things, some organization will be there. For example, in lab, lab, these things are there. Biorad is there. Like that, some place should be there to validate the data. Otherwise, everybody present their data and it will be a. So validation is also important for.
Certainly. Thank you so much. I think Dr. Narayan, you should go through the comments. And it's brilliant feedback, brilliant. I think it's been one of the best sessions so far. You certainly deserve a round of applause. Dr. Agarwal and I were in a fix yesterday when we heard that the speaker was not going to be there. And sir said, let's call Dr. Narayan. So thank you so much for accepting our last minute invite. And I must tell you, honestly, this has been the best session so far. And so much of clarity on what we really needed as an audience. And we would really love to have you more for contributing for some of our other sessions, because the doubts are far too many. So we will have to have you multiple occasions to take our audience through the key performance indicators, data validation, and really appreciate you taking your time. Thank you so much, Lingaiah sir, for moderating the session so well and for your enthusiasm to join us today. As a mark of our appreciation to Dr. Narayan Pendse, we offer this virtual certificate to you. This will be emailed to you as a speaker for this international webinar series and for your talk on key performance indicators for clinical quality improvement. Thank you so much.
Thank you so much.
Have a great evening. Enjoy learning together. We are 10 years and we are growing. Join us in this journey. Join the CAHO fraternity, family, and become a member of CAHO. Thank you so much. Thank you once again, Dr. Narayan. Thank you, Lingaiah sir. Best wishes.